I'm going to talk to you a little bit more on the clinical decision-making side, so the counterpart to John's policy insurance side, about how we can actually diagnose and ameliorate bias using machine learning in clinical settings. So one of the amazing facts about poverty and social disadvantage that I think Mario and I both saw when we were practicing medicine in the emergency department is how much pain is part of people's everyday life when they're in poverty. And so there are just these enormous pain gradients, somewhat by race, but more strikingly by income. So this is just the prevalence of severe pain, like everyday severe pain, by quartile of income, and also by education. And so I think that it's really important to keep in mind that of all of the ways in which poverty affects people's lives, this is a really, really difficult one that is pretty much an everyday experience. Now, there's an obvious explanation for why this might be, and I think that fits with a lot of our sense of how poverty manifests itself in the body, which is that poor people just have more painful conditions. And so that's true to some extent. So we're going to be using as a running example here osteoarthritis, so degeneration of the joints. This is, if any of you have ever gone to a doctor with pain in your knee or your back, and if you have at least one gray hair, the doctor is going to tell you, oh yeah, that's osteoarthritis. It might go away, or it might not. But it turns out that we have formal diagnostic criteria for arthritis, and we can see the same kinds of gradients by income or by education as we see in the prevalence of pain. And so really the obvious explanation is, well, why do poor people have more pain? Well, they have more things like osteoarthritis that cause pain. Makes sense. But it turns out that that's not actually what's going on. Which is kind of surprising. So because we measure both pain and osteoarthritis, we can actually adjust for the prevalence of these painful conditions. And so we can compare two people who have like the same degree of arthritis in their knee and see what that does to these gradients in pain. And so concretely, what we typically do in these studies in the literature is we take patients who have the same degree of arthritis on their knee x-ray, according to the radiologist, so two people, same looking knee, and see who has more pain. And it turns out that even when you take that difference in severity into account, Black patients, lower income patients, lower education patients, all of these patients still have more pain. So even though their knee looks exactly the same on the x-ray to the radiologist, they have more pain. So the literature has a lot of explanations for why this might be. But I think if you boil it down, the basic message and the basic conclusion the literature has come to is that if the source of the pain isn't in their knees, then maybe it's in their heads. And I don't mean this at all pejoratively. I think that a lot of this research draws on very established biochemical mechanisms that show that stress actually makes the same degree of a physical ailment more painful. Isolation, loneliness, psychosomatic factors, coping skills. So there's a ton of research in the biomedical literature on how this can happen, how the experience of pain can be so different from the actual physical ailments that doctors are diagnosing people with. There's another few strands of literature that look at disparities in treatments, in access to physical therapy, et cetera, suggesting that maybe doctors are treating disadvantaged patients differently. But I think if you look globally at all of these explanations, what do they have in common? All of these things are not in their knees. So we've kind of looked at their knees look the same, disadvantaged patients have more pain, so the obvious conclusion is the source of the pain is not in their knees. Makes sense. There's one observation, though, about what I'll just refer to going forward as the pain gap. So this is that gap in pain between black and white, between educated and not, between rich and poor. And that's that, if we look at that main finding from the literature, that pain disparities are still there even after we adjust for the severity of disease, here's what that looks like concretely. So patient has some pain, maybe it's severe pain. The patient gets an x-ray. the radiologist looks at the x-ray and says, looks normal or looks fine. And so our kind of global diagnosis is like, well, the problem isn't in your knee, it's somewhere else. Now, that depends very much on how we're measuring the severity of that disease. Because of course, if we're not using an accurate measure of disease severity, then the pain could still be in the knee. And so how do we actually measure disease severity? Well, this is how. So a radiologist looks at the film and grades the degree of osteoarthritis severity. And even though, this guy looks very reputable, he's looking very carefully, he's got a pen, he's pointing at the knee. That's the knee, by the way. So the fact that our measurement technology is basically this guy suggests that there actually could be something that we're missing. So there could be objective problems in that very x-ray that doctors are just not recognizing. And so given that, if we have any uncertainty about how we're measuring disease severity, there is some chance that we're just not picking up on things that are in the knee after all. So this patient with severe pain, a normal x-ray, could actually still have a knee problem. We're just not seeing it. And I think the reason that at least if you're kind of a student of the history of medicine and the ways in which medical knowledge is produced, you'll I think find this story at least somewhat plausible. And I'll give you an example just to continue the knee arthritis explanation. How do we actually concretely measure the severity of arthritis? Well, there are these objective grading systems where the radiologist checks off certain features on each quadrant of the knee and in each compartment of the knee. And so the most common was developed by these two doctors in the 1950s, Kellgren and Lawrence. And what they were doing was studying the prevalence of rheumatism and arthritis in coal miners, or colliers, as I learned they were called when I was reading about this, in Lancashire, England in the 50s. And very tellingly, if you go back to these original studies, they actually don't even mention anything about the racial composition of the patients they were studying, because I guess when the variable doesn't vary, you don't need to say anything about it. But I think it's very plausible that the medical knowledge that was built up in this particular time and place might actually not represent the medical knowledge that we need to make sense of the experience of pain today and in diverse populations. So why am I telling you about this? Well, I think if you heard anything about our what the speakers were talking about yesterday, you'd think like, well, this is actually an interesting job where we could potentially use algorithms. And so, there are many versions of the slide, but this is the classic ImageNet performance slide where you see that over the years, algorithmic performance is getting better and better and better. So this is lower and lower error rates until in 2015, the algorithms surpassed human performance. And so, it's only natural to think that if humans are overlooking subtle things in x-rays that might explain the pain of disadvantaged patients, maybe algorithms could do better. So we'd like to train an algorithm to help. We'd like the algorithm to do better than the humans. But how do we actually do that when our typical approach to training an algorithm in this setting is to train the algorithm on what the radiologist sees? So this is exactly what we don't want to do in this setting. If we're worried about the humans not seeing something, the last thing we'd want the algorithm to do is to learn exactly what the human is doing and replicate those mistakes. And actually, this is one of these cases where we're thinking about this problem in medicine actually helped me think a little bit differently about the rest of the literature too. Because it made me look at this graph and think like, well, what does that actually mean that ImageNet, that these algorithms are doing better than human performance? I don't know if you guys saw this. This is the most recent thing on Reddit about cat pictures, but sorry, I gave it away, but that's a cat. It's not a baguette or whatever. But it's not, when the algorithm does better than the human, the algorithm isn't going into this person's living room and being like, no, it's not a baguette, it's a cat. It's not like, oh no, these aren't three people playing football, they're playing rugby. The algorithm's performance cannot be better than human performance because the humans tell us what's in the image. So there's this deep way in which even in these image recognition tasks, it's not clear what we mean when we say that the algorithm is doing better than the humans. And we see that problem a lot in medicine, where the labels are much less certain than, is this a cat or is this an elephant? So there is another possibility. So what if there's another way to train the algorithm that doesn't require us to kind of lock into the human's judgment? So what if instead of learning from the radiologist, interesting. That was supposed to say Kellgren-Lawrence grade 2 or something like that. So instead of learning to grade the image like a radiologist, what if they actually listen to the patient? So instead of learning to replicate the grade of osteoarthritis that radiologists produce, what if they learn to look at an image and say, this is the amount of pain this patient is in? So rather than learning from the radiologist, we're learning from the patient. Now, there's one big problem here, which is that finding the data to do exactly that task is not that straightforward. So it's very easy to find data sets of x-rays linked to what the radiologist said about the x-ray. Those data sets are sitting on every hospital's radiology information system because that is produced in the daily business of the healthcare system by radiologists reading images and being paid for that. The health system does a much worse job of actually listening to patients and recording what patients say in any objective way. So you can't just go to a hospital and get a data set of the x-ray linked to 5 out of 10 pain score. You actually either have to painstakingly scrape all that together from the physician notes and link that to the x-rays, or you have to find a data set of a longitudinal study of lots of patients in lots of different parts of the country that has done that for you. And so there was such a study, and it was actually funded by NIH. It was done at lots of hospitals across the country. And so how did we get the data that we needed to do the study? Well, I emailed the NIH people and the PI at UCSF. I was actually still, this was before I came to Berkeley, so I was still in Boston, but we were like packing up the house and getting ready to move to Berkeley. And one of the people answered me and was like, well, we can't give you the data because there's all these like access restrictions and stuff like that. But actually, did you know that like this guy at your hospital in Boston was another one of the investigators? Have you tried talking to him? And so I emailed him, and I was leaving like next week, and he was like, well, if you just get me a hard drive and drop it off in my mailbox, I can just dump all the things, but it's going to take 4 days to copy all the images. And so it was like, getting to like when I was leaving, and I was like, oh my God, this is such a, but we ended up getting the data. And that's how we got the data to do this study. And once we had this hard drive, which I then kind of like carried across the country physically and gave to Emma at Stanford, once we had the data, this was a very straightforward machine learning problem. You get all the images, you put them through a network, and you have the network just predict for this image what is the degree of pain that you think the patient is in. And note that what we're doing is we're taking the pixels of the knee and we're predicting pain. So if the algorithm can accurately predict pain from those images, then by definition, the pain is in the knee. So that's a really kind of neat way to apply machine learning to this task. So here's what we found. So I'll show you just a few data points that look like this. So this is the pain gap. So this is the difference in pain scores that black patients report versus the difference that white patients report. So what does it mean to have a gap of 10? The maximum score, so like no pain at all, is 100. Severe pain is 86. So 10 points is like well on the way to severe pain. So this is like a large difference in pain between blacks and whites. And this is simply like the mean difference, like black versus white. If you control for this standard severity measure, the Kellgren-Lawrence grade, you do have some part of that disparity reduced, but only by about 9%. If you swap out the KLG in the regression and you just control for the algorithm's predicted pain score instead, you actually reduce that disparity by 43%. So that's about 5 times more than the standard way that we grade x-rays. And so once we take the algorithm's predicted pain score into account as our measure of severity of disease in the knee, we actually go a long way to reducing those pain disparities between black and white, or at least explaining them. And we have similar results for income and education, where the same approach reduces the gap between rich and poor, between educated and less educated. So we can say a couple of things about the model, and maybe there's one thing that's worth pointing out in particular, which is why is the algorithm able to find this signal, that explains the causes of pain that disproportionately affect black patients, less educated patients, and poorer patients. The set of patients on which we trained the algorithm, unlike the set of patients in Lancashire in 1953, was very diverse. And we can show that empirically by comparing this reduction in disparity after we retrain the model on a set of only white patients. So we take out all of the poorer patients, we take out all of the black patients. If we take out those disadvantaged patients and retrain the model on a homogeneous set, we do far worse in explaining those disparities. And so one of the key advantages of this particular data set is that it contains the experience and the needs of a very diverse set of people across the country. The other, I think, important thing to point out about the model is that it seems to be finding signal that's real and not something spurious about the images. So this isn't specific to the KLG score. We can run it with other scores. We can run it on MRIs. We find the same qualitative effects. It's not just a more granular version of that score. It's not a recombination of features that the radiologist already knows about. So if we try to explain the variance in our prediction with the features that the radiologist has meticulously coded, we don't explain that prediction all the way. So there's something new that this algorithm is finding that radiologists are not seeing because they're not trained to see it, because the medical science just hasn't been formed on a diverse set of patients. There's a concrete implication to all of this, and that's related to how we manage arthritis. So arthritis, it turns out, especially in the knee, is entirely treatable with a knee replacement. And when you hear patients describe their experience of a knee replacement surgery, it is life-changing. Like, people who just could not leave the house because of excruciating pain are like jogging again. So it is really just, it's one of the triumphs of modern medicine. But of course, that surgery is only offered to people who have severe disease in their knee. We're not in the business of replacing the knee of people who have stress or other causes of pain that are not in the knee. It only works if the problem's in the knee. And that's a problem, because you can think back to that poorer, less educated, or black patient who has severe pain. Their X-ray doesn't look as bad as you'd think, but the algorithm sees a lot of signal in the knee to explain that pain. That patient is, of course, going to be less eligible for these surgeries than the patient who has the textbook arthritis of the knee. And we can actually quantify exactly how big that effect is by doing a simulation of, like, well, today we assign surgery effectively based on the severity of arthritis and the degree of pain that someone's in. So what if we instead compared that rule to a rule where it was severe pain plus not the human measure of severity, but the algorithmic measure of severity that we've developed? And when we do that, we actually get double the eligibility of black patients, for example, for knee replacement surgery, precisely because black patients are more likely to have this different type of severe disease in the knee relative to the white patients, similar for rich and poor. And there's a version of this this is a nuance, but it's important. When you look at the number of knees belonging to patients who are in severe pain but not eligible for surgery because they fall below the threshold that we usually set in our guidelines for how bad disease needs to be before you're eligible for surgery. Of course, the algorithm, this is just the kind of the converse of the other slide, the algorithm does better on that. So there are fewer black knees that are in severe pain but ineligible. And the reason that's important is because these are the patients who are most likely to have their pain managed not with surgery but with medications, including opiates. And so part of the problem here is that we're saying, well, this isn't something we can treat with surgery. Why don't you have this medication? Why don't you try this oxycodone? And I think that's a major problem as well. So I'll just wrap up by leaving you with a couple of thoughts. We're with very good reason, today we are very concerned about bias in algorithms. And I think that a lot of those worries are real and need to be taken very seriously. But I think that this project, as well as a couple of others that I'm working on, actually have given me personally much more cause for optimism about the role of algorithms in exactly this area. And so, of course, algorithms can learn biased labels. They can learn to predict in biased ways. But they can also learn to listen to patients, and they can learn to accurately represent the experience of the poor and the disadvantaged. And which one of those algorithms do, it's not up to the algorithm. It's up to us. It's up to how we form those predictions, and especially in this setting, what data we use to train them. And I think that's why it's frustrating and even a little bit scary that, like, how did we get the data to do this study? Basically because it fell off a truck. This is like the academic equivalent to like data falling off of a truck. It happened to be the case that I was at the same hospital as this guy, the timing worked out. We're not the only people who have like interesting little research projects that we'd like to explore. There are lots and lots of people out there who have great ideas about how to train new algorithms to do really wonderful things, and we'd like to take advantage of that huge, that groundswell of human capital, because there are a lot of computer scientists who need data to write papers and have great ideas. And so this can't be something that's dependent on just us, being at the same institution as someone who has the data. That's madness. And so the last thing I wanted to tell you guys about is a project that I'm involved with, along with Sundal at Booth, and most importantly, with very generous funding from Schmidt Futures. Thanks, Tom. And it's called the Nightingale Project, and I'll just briefly describe it to you in case you guys might be interested in or know someone who's interested in participating. So the idea is that this is an open platform for doing this kind of research in health. So what is it exactly? We work with people and organizations who have interesting data just like this. So images, waveforms from electrocardiograms, biopsy specimens, pathology, things like that. We invest in a hospital system, working with regional health systems in Europe and outside the US as well. We build up those data assets within the system. So they own that asset. They can do research with it. They can do whatever they want with it. In exchange, we take a de-identified subset of those data. And an interesting trick here is that images and waveforms are actually not patient information in the eyes of the law. So we take a subset of those data and we put them on the other side of the platform, where we make those data available under specific data use agreements to researchers who want to do stuff with the data. And it's all not for profit. It's purely research oriented. And it's very different from the kinds of data sets that we see elsewhere. So if you look at the data sets that are out there, they are largely the image linked to what the human said about the image. And as we saw, that's kind of it puts a ceiling on how much we can learn from those images. What we want to do instead of learning from the human is we want to learn from nature, and we want to learn from long-term outcomes, and we want to learn from people's experiences, not just what the radiologist said. And that's the kind of research that we're trying to promote. And essentially what we're trying to do is bring that common task framework and model that worked so well for driving performance in ImageNet and all of the other computer science data sets for vision. We want to bring that to health. So I'll stop there and
great.
Here.